diaphragmatic hernia, there could be the liver may have received some damage due to the herniation into the thoracic cavity. There is nothing here from this one.
So for the radiograph, for the radiological findings, we noted a discontinuity of the diaphragmatic silhouette here, and the loss of cardiac silhouette, as well as the presence of the liver outline here, ventral to the cardiac silhouette. So for the radiological diagnosis, we diagnosed it as diaphragmatic hernia. And for the VD view, we noted a discontinuity of the diaphragmatic silhouette that is ventrally, as well as the loss of cardiac silhouette, as well as a increase of radial opacity of the right thoracic cavity. Our radiological diagnosis was also diaphragmatic hernia. So for the pre-op treatment plan, we gave lactated ringer solution from day 1 to day 2 as maintenance fluid, and amoxicillin to prevent any post-op infections.
So for this case, the anesthetic protocol for this case, Ginger was classified as ASA class 3. Therefore, and also the surgery was done on a slanted surgery table. For pre-medication, tramadol 3 mg per kg was given subcut, as well as hydrocortisone 5 mg per kg with slow IV. Induction was done with propofol 5 mg per kg. IV maintenance was done with isoflurane as well as IPPV, and intraoperative management was done with dopamine and morphine. So for the surgical protocol, diaphragmatic herniorrhaphy was done. Prior to surgery, Ginger was oxygenated just for support. So the skin was prepared from the caudal 2/3 of the thorax to the caudal abdomen. The cat was put on dorsal recumbency, and the skin incision from the xiphoid to the caudal 1/3 of the abdomen was made. Next. So after the subcutaneous and linea alba incision was made, the falciform fat was trimmed and removed to improve visualization, and here is where the hernia tear was identified. So upon closer examination, it's found that Ginger has a total circumferential tear on the right side of the diaphragm, a partial radial tear, and a partial circumferential tear on the left, as shown in this diagram. Next. So this is how the tear is illustrated in the book. So for easier understanding, we've drawn it out this way. Next. Okay. So although the picture doesn't really show it well, after the tear was identified, we looked at the lung inflation during IPPV, and what we could see was that the areas marked in red, so in this case, the caudal, middle, and partial cranial right lung lobe were atelectic, as well as the cranial left lobe, lung lobe. So the ones in red are atelectic, and the ones that are not marked were still viable and inflating upon the IPPV. So after the abdominal organs were removed, so what were the mostly mesenteric fat and liver was herniated into the thoracic cavity, and the spleen was displaced into the cranial medial abdomen. So after the removal of the organs, they were gently retracted into the abdominal cavity. The diaphragmatic tear was closed using PDS 30 using simple continuous pattern, and this pattern was also incorporated with the 13th rib to ensure that there was a secure hold on the suture. Next. So here is once the suture had been closed, what we did was examine all the abdominal organs to check for viability, any ischemia or injury. So here we can see on the left photo that there is a bit of fibrosis on the liver, and on the right we can see that there's also some cirrhotic areas as well, which explains the elevated ALT. Apart from that, all the other abdominal organs were fine, and luckily there were no adhesions observed in the cavity. Next. So after the examination of the abdominal organs, thoracocentesis was done with a butterfly catheter through the diaphragm. So the amount of air that was aspirated from each side is shown as below. On the right side is about 420 and the left side is 14 mil. Next. So then routine closure was done. The linea alba was closed with 30 PDS, simple continuous pattern. The subcutaneous layer was closed with modified Cushing pattern, and the skin layer was closed with simple continuous using 30 ethylon. And then we bandaged the suture site. So on the post-op radiograph, this is the post-op radiograph taken. Next slide, please. So if you can compare it from the previous radiograph, we can see that the diaphragmatic silhouette has been restored and there is no more protrusion of abdominal organs into the thoracic cavity. Similar findings here for the for the VD view, and also we did not note any pneumothorax from both radiographs.
So for the post-op treatment, sodium Cortef was administered slow IV to prevent the immediate re-expansion of the lung, and marbofloxacin was also given as a broad-spectrum antibiotic, and lactatus ringer solution was given as maintenance, and Glutamax was given as well to support the liver.
So for the progression of the case, Ginger is bright, alert, and responsive, and he is also eating and drinking well. There is no more observation of abdominal breathing, and upon auscultation, the dull lung sound of the right caudal lung lobe has been reduced significantly upon auscultation. So here in this table, it shows Ginger's SpO2 levels. Before the surgery was done, her SpO2 levels would fluctuate between 80 to 90 without oxygen support. And on oxygen support during the surgery, right after the complete closure of the diaphragm, the SpO2 rose to 89 to 90%. So the prognosis for this case is good because Ginger did not face any complications throughout the surgery. No adhesions were found and she recovered well post-op. So for client education, Ginger needs to be on strict cage rest for 2 weeks to really allow the diaphragm to heal properly. And the owner should also monitor breathing. So if the cat has difficulty breathing, they should immediately send him to the nearest vet for oxygen support and come back for suture removal after 2 weeks. Thank you. Any questions? Good morning, Dr. Chen. To answer your question, which sutures need to be removed? In this case, the suture from the midline incision, the ciliotomy. So in 2 weeks' time, Ginger can come back and get those sutures removed. So PDS was used for the closure of the linea alba and subcutaneous layer, but the skin layer was closed with 3,0-ethylene. Morning, Cindy. So, to answer your question, how does hydrocortisone prevent the re-expansion of the lung? So the thing is, how the re-expansion of the lung happens is because, as I mentioned in the previous slides, there were some areas of the lung that were atelectic. So, what happened is after the surgery was done, we did the thoracosynthesis and then we restored the normal um, after restoring the negative pressure and the normal tidal volume, we are worried that what will happen is um, that the pressure will cause the air to enter the lungs immediately. So it's like air will be forced into the lungs. So this can be also like a acute uh, this can be an acute process. So hydrocortisone is given as like a short-acting anti-inflammatory as well to reduce the inflammatory process in the lung during the re-expansion. Hi, so a question from Shazwin Taufik. Why was the surgery done on a slanted surgery table? So in this case for the diaphragmatic hernia, the surgery was done slightly slanted where the head is elevated from the body. This is just to help the doctors gently evacuate the abdominal organs from the thoracic cavity, just to like have the grip, have the gravity aid with it. Doctor, if there are no other questions, shall we proceed to the next case?
Okay, next case, please. So, Assalamualaikum and a very good morning to doctors and everyone present here today. So, our rotation group 1 will be presenting on another case of a rectal prolapse reduction in a domestic short hair cat. So, this not so handsome cat is Bob, a domestic short hair male kitten weighing around 1 kilogram. It was managed as a semi-Roman cat and was fed with dry kibbles, and the vaccination and deworming status was not up to date. So the history for this cat was 2 weeks ago, the owner started to notice that Bob was having this rectal prolapse dangling from the anus. So he brought the cat to a private vet and the problem resolved. But 1 week ago, the rectal prolapse reoccurred again. So on yesterday, on 11 November 2021, Bob was presented to UVH. On physical examination, the TPR was within the normal range and Bob was bright, alert and responsive. There was around 5 centimeters protrusion of a cylindrical mass through the anus, and this tissue appears to be inflamed and edematous. So we come up with a first probability of the rectal prolapse, which could be due to excessive or chronic straining, which can be due to either GIT, parasitism, or enteritis. So the plan was to do a manual reduction plus first string suture. For the anesthetic protocol, this cat was categorized as a ASA class 1, and it was pre-med with tramadol and aspromazine. The aspromazine helps in reducing the usage of propofol and helps in recovery later on. So for the induction and maintenance, we use propofol 5 mg per kg. And since this is a kitten, we need to manage the hypothermia induced by the anesthesia. So we give constant heating support using a heating pad. So for the procedure is the rectal prolapse reduction and first string suture. Firstly, next. Firstly, the protruding rectal tissue was cleaned and lavaged using a cold hypertonic solution, which is in this case, we use a G20 solution and also an ACL to reduce the swelling and edema of the rectal prolapse. Next, after we lavage, we manually reduce the rectal tissue by lubricating it and replacing it digitally using our finger and into the anus. And then a 1 ml syringe was inserted into the rectum to make sure there is no interception. Next, then a first string was made while having the 1 ml syringe inside the anus. This is to make sure that the hole is small enough to prevent any prolapse, but can still pass through soft feces, which is in this case, we use the 1 ml syringe so that the feces is around 1 ml in diameter. 1 cm in diameter. Next. So the post-operative treatment for this, we use lactulose as a stool softener so that the feces is soft enough around score 1 or score 2 so that it does not causes a prolapse of the anus but still allow pass through of the anus with the first string suture on. Then we gave worm nail parental at a dosage of 10 mg per kg oral for every 2 weeks until 12 weeks of age, and then change to every month. This is as an anti-parasitic agent against any gastrointestinal parasite. Since the history, this cat was not dewormed yet, so we highly suspect that the gastrointestinal parasite causes the tenesmus, which causes the rectal prolapse. And during the first string suture duration, it should be fed on low fiber diet to reduce the consistency of the feces. And the first string suture can be maintained up to 5 days to prevent the recurrence of the prolapse. So immediately post-operatively, the progression, we can see from the left side, the cat was able to pass through soft feces around score 2, and the first string was still intact with no prolapse seen. So for the prognosis for this case was good, since if the underlying factors can be addressed and the cat does not strain anymore, causing the prolapse. So for our client education, we need to educate the owner that if recurrence occur, it can be because of the underlying factor is not addressed, which causes the excessive straining. And to regularly deworm the cat, especially this cat, since it is an outdoor cat, which is predisposed to having a gastrointestinal parasite. And to make sure the lactulose is being given throughout the first string suture duration, and to ensure after the first string suture removal, the cat should have a proper high fiber diet with adequate water intake. So that is all for our case. Is there any question?
Hi, can you hear me?
Yes, doctor.
If this case keep recurring with these procedures, what is your suggestions?
So if this case keep on occurring, we can opt for colopexy, which is the suturing of the colon into the abdominal tissue to prevent any prolapse again.
So if the prolapse part is gangrenous, what is your next procedures?
If from the examination of the prolapse rectal tissue, we find there's any gangrenous or necrotizing tissues, we can option for colectomy, which is the removal of the necrotizing part.
So after you remove the necrotized part, what do you do?
We check for if there's any secondary bacterial sepsis. If it is indicated, if there is an infection in the system, we can opt for giving antibiotics.
And in the worst case scenario, we will proceed with anastomosis, doctor.
Have you heard something called rectal pull-through?
Yes, doctor. A rectal pull-through is like the colectomy, but without ciliotomy, right, doctor?
Please revise your readings on rectal pull-through procedure, yeah? Thank you.
All right, doctor. Thank you.
Again, what is the possible primary cause of this rectal prolapse?
For this case, we suspect there's infestation of gastrointestinal parasite in this case, which could lead to excessive straining in this cat. So if the cat keep on straining, it can cause the prolapse of the rectal tissues.
If these problems keep reoccurring, you should do.
If this problem keep on recurring, even though we try to address the gastrointestinal parasite, we can look. We should rule out the possible of enteritis also.
And at the same time, how you manage the prolapse? You keep doing the first strings, sutures, placements, or what?
For the recurring prolapse, we can option for colopexy, or and if the prolapse rectum is already necrotized, we can option for a colectomy.
What's biopsy will help?
I'm sorry, doctor.
What's biopsy help?
No, no biopsy was sent.
No, it's in case it keep reoccurring. Would biopsy help?
If this problem keep on recurring, we can do a biopsy to check if the enteritis is immune mediated.
But what do you mean by immune mediated?
In cases of immune mediated enteritis, we can see there is infiltration of eosinophilic cells into the intestinal tissues, which can cause the enteritis and also leads to excessive straining.
Got any treatment for that?
For this case, we do not address any arthritis since we do not suspect it yet. But if the problem keep on reoccurring, we'll probably look up for it.
Okay.
So is there any more question?
If there is no more questions, I think we can end around.
Okay, doctor. Thank you so much, everybody, for coming today. This will be the last rounds of the semester and also our last rounds at BVM5. So we would like to thank all the lecturers, BOs, as well as staff for guiding us throughout this semester for our rotations. And to all DVM5 Lanjutan, good luck for your upcoming OSCE as well as CE. And also, if you missed the message earlier, our briefing will be at 10 a.m. instead of 9 a.m. So once again, I'd like to thank everybody and have a nice weekend.
All the best to DVM5 for your final and comprehensive exams. Okay,
Thank
good
you
luck.
so much, Doctor.